First, let's think about what are the limitations of what we could do now. So we use surrogates at single points in time to identify patients' risk. And so if a patient, particularly our patients with HER2 positive and triple negative breast cancer, if they receive neoadjuvant therapy, we really hang a lot on pathologic complete response because we know that that portends a good prognosis. But what if they have residual disease? Really, right now, patients are going to be getting escalated therapy because we know that that's a higher risk of recurrence. But it's a single point in time, and so we're really assessing an overall risk of recurrence without continuous monitoring subsequently, and are having to make estimations based on data that we have from PCR, from pathologic complete response. Tumor markers, so we do have blood-based biomarkers, but they're not sensitive. They definitely have a poor positive predictive value for recurrence and are not used in practice for this reason, so they're just not applicable to the patient population, the questions we would want to answer. And then imaging tools, as we know, it's not standard of care to do any imaging besides breast MRI or mammography in patients that have residual breast tissue. But otherwise, there has been no improved outcomes based on surveillance imaging, so it's not recommended unless a patient reports a symptom. Now, thinking about our responses to adjuvant therapy and monitoring for recurrence, so the MRD space. And so here we talk about EBLIS, which really is a fundamental study for us to think about what we can do, what we can glean from early identification of ctDNA. So this is the Exploratory breast lead interval study. This is the longest ctDNA study follow-up to date, and the primary objective was to determine the lead time of ctDNA positivity prior to clinical recurrence. And so patients how early can you detect ctDNA prior to what's already standard of care, the regular screening intervals that we have. This has been updated multiple times over, but at this point it was 188 women with high risk stage 2 to 3 breast cancer of all subtypes. There was 156 patient samples that were analyzed with the Signatera assay, and then you can see this breakdown that the majority were HR positive, HER2 negative, but we also had triple positive breast cancer, triple negative, and 8 HER2 positive patients as well. And so I'll just kind of pull these up automatically because they're really impressive. So the relapse-free survival and the overall survival. So ctDNA positivity is in the green, and then in the blue is negative ctDNA detection. So for relapse-free survival, it's a hazard ratio of 30, and an overall survival hazard ratio of 19, so very convincing. If you are ctDNA positive, and again, let's go back and just think about the science and think about the biology. If you have a very specific assay and you're actually detecting ctDNA, it should not be in circulation unless there is residual or recurrent cancer, and so that's kind of your first herald. But now we actually have clinical data to say, yes, it proceeds. And so then the question, by how much? So again, ctDNA, worse recurrence-free and overall survival. It was detected in 30 out of 34 patients, so an 88% sensitivity. And importantly, 10.5 months lead time over radiographic recurrence, and it went as far as 38 months. So there were some patients that over 3 years prior to clinical recurrence were having ctDNA positivity. You can see this broken down by the HR positive, HER2 negative, which was the largest group. The HER2 positive, we talked about, that was a smaller group of only 8 patients, but 15.7 months, and triple negative, 8 months, and then the triple positive, a median of 6 months.